Thank you for coming to the inaugural seminar of the AI for Mental Health initiative, which I'm leading. My name is Killian Pohl. I'm a professor in psychiatry, and I would like to take this opportunity to quickly introduce the initiative to you. So almost daily, you can read about articles about the potential impact of AI on psychiatry. Now, I'm curious how this hype has impacted your work, and this is the short audience participation part. So, but it's confined to raising your hand. So my question is, can everybody raise their hand who creates AI or uses AI in their work? Anybody? Fantastic. So keep your hands up. Keep your hands up. Don't take it down now. Keep your hands up if you trust AI. Anybody? So there are a couple, look around, there are a couple of hands up that are still trusting AI, but the hands are not as many, let's say it this way. So for this technology, and you can take your hands down now, by the way, for this technology to have lasting impact on psychiatry, we envision in this initiative to build trustworthy and ethical AI that will transform the field from subjective observation to objective precision, resulting in more effective and accessible research and care. And the way that we do this is we build on the extraordinary resources provided by Stanford, the School of Medicine, and specifically the Department of Psychiatry, which is unique in its faculty comprising AI researchers like myself and mental health experts. In our initiative, the AI labs have been and will be continuing to develop tools for specific applications in psychiatry. And those tools are then integrated into clinical practice by implementation scientists. And all of this is possible because we really want to foster an interdisciplinary culture among AI researchers and clinicians that spans beyond the department and also will involve, for example, industry. We hope that this seminar is basically an example of this interdisciplinary culture and also complements the teaching that we do with respect to AI and psychiatry for the School of Medicine. All of this is done under the principle of ethics and rigor, which is very essential to us. Essential also to the initiative is the leadership committee, which is comprised of the faculty that you see here. And I would specifically like to thank, where is he sitting, Dr. Kaustub, for inviting Tom Insel to this seminar and helping a lot, and also Mr. Zhu, where are you, for helping me a lot with the administrative parts in the background. But before we introduce Dr. Insel, I wanted to keep you aware that there are more events happening. The next one is a joint seminar with the Tech Hub on Ethics of AI and Clinical Practice. That is May 14th. And then we'll continue this seminar series every fourth Wednesday in the month from 12 to 1. And our next speaker is going to be Dr. McManus, who is the Deputy Chief Technology Officer of AI at the Department of Veterans Affairs. And we are really excited to hear her experience of integrating AI technology into psychiatric care of the VA. This is followed, the speaker in June is Dr. Dawson. She's the Director of Center of Autism and Brain Development at Duke University. Finally, I'm thankful for the financial support of members of this community and the Department of Psychiatry that made this initiative possible. And a very special thanks to Dr. Roberts for initiating AI for mental health. Now, to introduce the distinguished speaker of this seminar, Dr. Tom Insel, I'm handing over the baton to Dr. Rodriguez. She's not only a member of this initiative, but also the Associate Chair of the Department of Psychiatry and the Associate Dean of the Academic Affairs of the School of Medicine. Thank you.
Thank you so much, Killian. I wanted, first of all, convey Dr. Roberts' incredible enthusiasm for the initiative. She wishes she could have been here to introduce you. Unfortunately, she's sick, and she, asked me to say a few remarks. To me, you are somebody who needs no introduction, but we were excited to introduce you to the greater audience. And we're really excited to have you open this important conversation. And you really shaped the landscape of mental health research, policy, and technology over the past several decades. And before I give your bio, I just want to say a few words, which is I met somebody who had participated in one of your very first NIH clinical studies. I study OCD research, you do OCD research, and the work that he participated in and is published then impacted a citation that I did for my NIH funded research. And we've written a little personal accounts about his time in your study. So your research really has really personal and profound impacts on lots of people. So I just want to say, it's not on your bio, but thank you. Tom Insel is a psychiatrist, neuroscientist, and a pioneering force in the mental health space. As director of the NIH from 2002 to 2019, he has played a central role in steering national research agendas and shaping how we understand the biology of mental illness. Since then, he has led mental health efforts at Verily and co-founded multiple startups aimed at transforming care delivery for access, including MindStrong Health, Vana Health, and Humanist Care, Neural Well Therapeutics, among others. Dr. Insel currently serves on several boards, advises on numerous health ventures, and is acclaimed author of Healing: Our Path from Mental Illness to Mental Health. He is also a member of the National Academy of Medicine and a recipient of numerous prestigious awards, both in the US and internationally. And today he'll be speaking to us on a topic that lies at the heart of our mission at AI for Mental Health. How can AI transform mental health care? So please join me in a warm round of thanks.
Wow, so this is, I've heard of singing for my supper, but not singing for my bottle. Thank you.
Let me just connect that for you. Okay. So you just have to plug it in here, and you should be all good. And I'll be out of your way. Does it work?
Let's see if that works.
Oh, we have to press share again. Share. Share.
Hmm.
Ah,
looks like that works. Great. Thank you, Carolyn. It's a pleasure to be here. Killian, you and Kashtub have been brilliant in pulling all this together. There's so many things going on right now. I was tempted to just come up and talk about the fate of the NIH and science in America and what's happening in academia, but I'm going to leave that for discussion later, perhaps, and really focus on this particular topic. There are people in this audience who actually know more about this than I do. So I'm not somebody who has worked extensively in developing AI as a tool, but I do have a deep and longstanding interest in fixing the mental health care system. And so the question I want to address with you is, how do these tools that have developed so quickly, at least it seems like that, how do they begin to change how we provide care? Just a word about disclosures. As Carolyn mentioned, I've founded several companies. I'm on several boards. I'm not going to talk about any of those, so we can take that off the concern. What I do want to talk about is kind of this context. This is not a new topic, actually. When you look at the history of AI, one of the very first applications when that term was first being used was back in the 1960s, when Jacob Weissenbaum developed ELIZA, which was this very simple kind of reflexive machine that was supposed to stand in for being a therapist. It was the days when Rogerian therapy, many of you may not even know what that is, was very popular. And what Carl Rogers had pioneered was the idea when a person says to you, "I'm feeling miserable," the therapist would say, "You're feeling miserable." So it was like just reflexive commentary, not particularly difficult to develop a set of rules, because it was a rules-based system that would just reflect back whatever the patient had said. That was ELIZA, and it was of great interest. It was covered, as I remember, in Time Magazine, lots of other places, kind of really fascinated the public for a while, didn't go very far. To me, the really important events around the development of what we call AI today is not the generative AI part, which we'll get to, but what happened maybe 12, 15 years ago. Interestingly, from people who came out of neuroscience or mental health. So Greg Corrado, who was here in Bill Newsom's lab, who went to Google and created TensorFlow. Demis Hassabis, I think he was at in Tom Poggio's lab at MIT, who went to DeepMind. So people who actually had this kind of background, and even someone like Mustafa Suleyman, who was doing peer support online at Oxford, got interested in this idea of figuring out ways to handle big data in new ways. And so TensorFlow and then neural nets, mostly developed at Google, were attempts to find a signal in lots and lots and lots of data where there was so much noise. And what was amazing was that whole movement towards machine learning, even 10 years ago, gave us the tools that I think we still need to apply, but are incredibly helpful and powerful for the kinds of things we need to do around the realm of diagnostics. Of course, the last couple of years have been all about generative AI and this ability to, whether it's to generate text or now speech and language and audio and video, but really now providing this interesting world of bots and co-pilots, which everybody's fascinated by. I usually have a very simple metaphor when I talk about this, which is to think about the history of how we've navigated, that forever we used paper maps. And we were there kind of in the 1960, 1980 world of paper maps. And then around early 2000s, by 2010, 2015, we started using GPS in a really serious way with the development of Waze and with every car then becoming equipped, certainly every phone becoming equipped with something that gave us a digital access to maps and to real-time navigation. That gave rise, obviously, from took us from taxi cabs to Uber and Lyft. And there's another jump now to the autonomous vehicle, to Waymo. I would say that in psychiatry, just to preview what else I'm going to say, we're still at the GPS stage. I don't think we're ready for Waymo, but that is the question, is what it will take to get from where we are to something that looks like an autonomous vehicle. And the way we should think about that, from my point of view, isn't to ask what the technology can do, but ask what problems we need to solve. And so to get at that question of what problems are really key, let's think about mental health and where we're at in 2025, which is really, everybody says we have a national mental health crisis. We have three crises that are really bearing down on us, not getting any better. There's a youth mental health crisis, there's SMI, serious mental illness, and there's the substance use disorder, SUD crisis. They're very different. They have different drivers. And if we want to solve those, we have to understand those in different ways. The youth mental health crisis, a true increase in prevalence, 52% increase in suicide, there's some mortality, about 105% increase in the number of kids ending up in emergency rooms for self-harm. The phenotype here is much more internalizing than externalizing. It's more girls than boys. And it's most concentrated in kids who would identify themselves as non-binary. It's very, very clear that that's the group at highest risk. SMI looks very different. This is not an increase in prevalence. We think the prevalence of schizophrenia or bipolar disorder probably isn't that different in 2025 than it was in 1925 or 1825, from what we can tell. But what we've seen is, because of the reduction in care, we have much, much worse outcomes, which has created a crisis in terms of incarceration, in terms of homelessness, and the fact that people with these disorders like schizophrenia are dying about 23 years earlier than the general population, not from suicide, but from common medical problems like heart disease, diabetes, and pulmonary disease, which is extraordinary, which is, again, a reflection of our failure to care for people with these illnesses, 15 million of them, that are really the most marginalized part of our population. I call them America's untouchables. And then the SUD epidemic is something entirely different, which has to do really with the advent of fentanyl, which is driving lethality. We're now close to 100,000 deaths per year. It's come down a little bit in the last year or two. But again, the solutions here are going to look very different from the solutions for youth mental health and SMI. Now, I break this out so you have a sense of how we need to think through mental health as a public health issue. But the reality is that individuals can be in all three of these buckets, and often are, because most people with serious mental illness get sick when they're teenagers or early 20s. Many of them develop substance use disorder. What I think you find as you go across all of these is a set of problems that need to be solved. And that I've listed them here. There's a problem with diagnosis. DSM doesn't work here. Engagement, most people are not in care. Capacity, quality, and accountability. And I think what would be really helpful is to understand that if we're going to transform care and get better outcomes, we're going to have to figure out a way to focus on each of those five and come up with solutions. And I think that's really where the tools will matter. So that's the talk I want to give, the story I want to tell. And probably the best way to do this is to go through and just take a moment to really break down these as problem statements. Like, what is the problem with diagnosis, with engagement? And we can go through each of them. Certainly the clarity problem is the diagnostic problem. We have such heterogeneity. The words that we use, the labels that we use, don't seem to have any matching to a biology underneath that we can work with. They often don't predict treatment or treatment response. We have a massive problem with engagement, more so than any other area of medicine. You don't often feel that when you're in the care system. It seems like we're being overwhelmed with demand. But at a population level, what you find is that more than half the people who could and should be in care are not. And it's even more extreme because often it's the people who need the care the most who are least likely to be engaged. Just the flip side of what you'd see in cancer or heart disease, where the most severe illness leads to treatment. Here, the most severe illness leads to avoidance of treatment. Capacity, you know this. There's just a big problem between supply and demand, and that's true on many, many levels. Quality is something I really want to focus on because so much of the digital mental health movement has been about access. That's good. It might help with engagement, but it's really quality that matters, and we don't spend enough time talking about that. And then finally, there's, I think, a profound issue with our lack of accountability, that we as a field have not delivered on specific outcomes. We haven't focused enough on measurement of outcomes. I was so glad to see Killian put up that slide about the mission here is to move from subjective to objective, because that's really what we need to be thinking about in this field where we have so few objective measures of whether someone's better or not. So humor me for a minute, because I want to give you an image for each of these so that if you're not in this field, you'll have a sense of what we're talking about. The clarity problem, the diagnostic problem, is that we're just dealing with such a mess in the labels that we use. They don't really have the kind of, at least at a population level, the kind of clarity or specificity. There's no precision. I think when I was younger, I had this idea that if we just did better and better science on genetics and imaging, we'd figure this out. That hasn't actually panned out all that well. What I'm going to try to convince you of today is that where we need to focus on is particularly on behavior and cognition, which is where AI really comes to the rescue. We'll talk more about that in a moment. Engagement, I just want to hammer this again, because it's so critical. At a population level, we're failing. We have this crisis because people are not in care. These are data that we collected when I was at NIH, but it looks like about 40% of people who should be in treatment or are in treatment, about 40% of those receive any kind of evidence-based care. A third get better, a third not so much, and a third don't really get any benefit at all. I call this the 40-40-33 rule, and it's really why we've struggled so much, I think, at a public health level here, because even though we may do really well with a few patients that we see, we're seeing a few patients out of those who are in need. And if you do the 0.4 times 0.4 times 0.33, you're down to like 6-7% of the population getting the benefit. For kids, it's even worse. Only about 20% are actually engaged in care. And we know that when you look at the medication assisted treatment, MAT, for opiate use disorder and SUD, it's about 10% getting what they should be getting. So it's really a problem that needs to be thought of in a very aggressive way. The capacity problem, you all know this, there's a shortage of psychiatrists and prescribers, particularly in rural areas. Something like, what does it say here? Psychiatrists, about 80% of counties, rural counties, have no providers at all, which is really pretty stunning. Again, not a figure that you'd see for the rest of medicine. So this is a problem that we've got to get serious about. And then the quality issue, there's lots of ways of thinking about this, but suffice it to say that we have a lot of people in the workforce who don't have the training to actually provide the care that works. And that's a huge problem for us. Again, not a problem so much in other parts of medicine. It'd be kind of unthinkable to say that 80% of oncologists had no training in an evidence-based treatment, but that actually is the number for psychological treatments and when you look at training of people who go through either LCSW programs or marriage and family therapy programs. So we've got to think clearly about how we train and how we provide services, especially to those with SMI. And then the last point about accountability, we don't measure. It's a data-free zone for the most part. This review, I think, was from like 2018, but it's clear that hasn't changed that much since then. And if you don't measure, you don't manage. That's a pretty basic rule. That's a problem that clearly AI can help us with. So that's a quick accounting of what we've got and what we've got to solve. Let's talk now for the rest of this time about what we can do and where we are in 2025 with solutions. I guess the first thing to say is there's a lot going on, and AI has really taken off as an area of investment for startups. I don't have a great number, but my guesstimate would be maybe between 30 and 50% of the venture-backed startups from 2023 until now are pitching based on their use of AI. Some of them, at least in mental health, some of them it is most of what they do. But at this point, if you were pitching to a VC firm and you don't use the word AI, at some point in your pitch deck, you're not going to get funded. Actually, even if you do, you're probably not going to get funded. But it is absolutely vital. I don't have all of the companies obviously on this list, but just a few examples of the companies that are here and the kinds of ways that they're trying to go after this whole set of problems in the mental health space. We'll talk about much of this, but suffice it to say, this is a very broad and exciting area with lots of innovation. By the way, lots of funding that has come in here. I kind of wonder about how to think about this in an academic institution, as at a time when NIH seems to be, this looks like it's going to be largely defunded in some areas anyway. And we know that pharma is not investing in CNS. It does feel like the startup environment is probably the place that a lot of innovation is going to take place. About $12 billion has gone into mental health startups since 2019, which is about equivalent to the NIMH budget. But the NIMH budget, 70% of that is the out years of grants that have been previously funded. So it's a lot of money. It's probably more than any of the NIH neuroscience institutes have spent. And as I said, a lot of this now is going into the use of AI for mental health. I'm going to just give you some examples, and what we'll do is go through each of those problems: the clarity, the diagnostic problems, the quality, each one of them in turn. We'll start with the diagnosis piece. And this is a company that I just learned about. I have no relationship to them, but they're a pretty interesting group. It's called Deliberate AI, and they've decided to take on the assessment of mental health in a kind of multimodal way. And this really leads to like one of the main points I want to make, which is that I think where the real power for psychiatry is, and what we've neglected over the last 3 or 4 decades, is our ability to get precise about behavior, emotion, cognition. I went into this field long time ago in the 1980s and 70s, when there was no other part of medicine that cared about behavior or cared about emotion. And there was really rigorous study of emotion and cognition and behavior in psychiatry and psychology. And I've witnessed and even been part of the whole movement that we want to be just like cancer. We want to be able to find the mutation, the DNA signals. We want to be able to find the imaging signals that will really help us with diagnosis. And in the meantime, we've really neglected the thing that we're probably uniquely qualified to do, which is the study of emotion, the study of cognition, and the study of behavior. What I love about what's happening in AI is it's taking us back to that. And this is just one example. There are many, many companies that have been using vocal biomarkers. So looking at, they're probably not really biomarkers, they're vocal measures, speech and voice, as these guys do. This group also looks at face and body motion, all these things that you'd pick up in a typical teletherapy session. But we don't bother to collect the data, but it's all right there. And the number of signals that you can pick up for patients who are on antipsychotics, just getting the blink rate, which is easy to pick up with teletherapy, can be incredibly useful. Capturing the speed and the prosody of voice, using the speech biomarkers or speech measures of sentiment, of coherence, of all of that, incredibly powerful. What this group has been able to show is that they can use these measures when they put them together to get measures of anxiety and depression that are actually surpass what you get with inter-rater reliability. So they're pretty good in terms of quality of, they really got started because they wanted to work on clinical trials. They're now beginning to work on clinical care. But it's quite clear that you don't need to give a Hamilton rating or a MADRS rating or even a HAM-A when you've been able to collect these multimodal measures. And what's interesting is that no single measure seems to do it, but putting them together, which is really an AI challenge, really helps you, gives you the additional advantage and the additional accuracy. So I think, if nothing else, one of the things that should happen pretty quickly here is our ability to do a better job on measuring behavior. And certainly, if we did nothing other than to collect voice and speech and maybe some aspects of face and bring wearables into the equation as well, a huge amount that we can begin to do to get better at knowing how's somebody doing. Now that partly can relate to diagnosis, partly can relate to looking at outcomes as well. We used to call this digital phenotyping. I'm not sure that really does justice to the quality of what we want, which is this not only multimodal, but it's something that would be continuous, passive, and highly objective. So that's the way I think about clarity and where AI can fit in. Engagement is a little different. There's been many attempts to see whether there's a way we can use AI to get people involved in care. And most of them have been pretty disappointing. There's one study that came out of a group called Limbic. It's a UK startup that is tied into the National Health Service. So this was a study of 129,000 people who were referred by their GP for mental health care. And they were then either they went through a chatbot or they went through a human to get into care. And what was pretty stunning, and it was still kind of hard for me to wrap my head around this, but what they found was that the bot was actually better than the humans at getting people into care. And they were surprised by this as well. What it turned out, the difference was there, but not incredibly big. 15% versus 6%, still pretty low for the general population. But for particular groups, particularly for more marginalized populations, it was really powerful. And you can see that in these slides, in the two graphs. I don't know exactly why that would be. They decided to take 42,000 people and ask them, why did you follow through with the bot and not with the person? And the answer was people felt judged by the human on the phone rather than having this ability to just deal with a bot. So there's something there that I think most of us found counterintuitive, but it seems to be important. I don't think this solves the engagement problem. I work mostly in SMI, so I think a lot about how we get people with SMI engaged in care, and I honestly believe that ultimately is relentless human contact. And I mean relentless. In our company, it takes 6 attempts to get a person to actually open the door for us in South Philadelphia to talk to one of our care managers. But I don't think there's an AI solution for that. But for these other issues around maybe more mild to moderate patients who are getting referred for care, this is something we need to look at. And Limbic, I think, is a pretty good example of how you can begin to study this in a large population. As an aside, I should mention that a lot of where I see the most interesting innovation in mental health care is actually in the UK. It's not in the US. And I think that's partly because the National Health Service has been open to trying to innovate. We're living in a very different marketplace where if you want to innovate on any part of the mental health care line, you're going to have to work with a payer and a health system. And that's often an 18 to 24 month negotiation. Very difficult to do that if you're a startup. And so this is actually a pretty unfriendly environment, I think, in terms of mental health innovation relative to the UK or to Germany right now. So Limbic, I mentioned, is through the National Health Service. Capacity, there's a lot to say here. And the first thing I'll say is that in California, if you look at our community mental health system, the biggest challenge we have is the workforce. There's just no question about it. We are really unable to keep frontline community mental health workers. And when you interview them, as I did when I was working on my book a few years ago, they were leaving to go to work for Target or Walmart or Costco. And I thought it was because the pay was better, which it was. But actually, they didn't take the job for the pay. They took it for the mission. And what I heard over and over again is we came to do this really hard job, and we're spending all of our time documenting what we do. In California, we have a public county system, county-based system that's a fee-for-service system. So to get paid, you have to document what you're doing in 3-minute intervals. So literally, these poor people who are on the front lines were spending 50% of their time documenting what they were doing with the other 50% of their time. And that's not an exaggeration. So that's an AI fix, right? You can use a digital scribe to collect all of that, to create the reports, to create translations as they're needed, to provide the codes, everything with the push of a button. And this is now broadly used in primary care. It hasn't yet been adopted so much by mental health workers, but imagine you'd basically double the mental health workforce in the state of California by using this one technology. And it allows us to really get people from being clerical to really being providers of treatment again. I think getting the other piece of this is getting ratings done automatically. I just showed you the example from deliberate AI, how they, can generate rating scores just from voice and speech. This is now becoming commonplace, at least in the innovation world, but it has yet to really move into the world of practice, the world of care. But the goal here ought to be really to maximize the time that frontline workers are spending with patients and families, and allowing them to really operate on what the very thing that they came to do when they joined this important mission. Now, that's a little different from the capacity issues of saying we don't have enough therapists. This is actually also a great UK study. I think it's the best study I've seen so far on using AI, in this case, as an assist for therapists. So basically what you have here are people in the National Health Service. This is in the talking therapies modality that they've developed in the UK, which is really a fantastic operation for delivering CBT and other treatments for depression and anxiety. And here what they did is, in addition to having the CBT therapist, they had this AI assistant who would contact patients on like an everyday basis and check on homework, provide support, do a bunch of other things. And they simply asked the question, could we reduce the amount of time that the CBT therapist is spending with patients without losing anything on the outcomes side? They were able to reduce therapy time, I think, by about 75%. So again, we're trying to get that supply-demand problem fixed simply by having this agent who was available to patients 24/7 to help on helping them overcome mild to moderate anxiety. You can see, I hope you can see the lines. The dotted line is what they got with their digital program. The name of this company is IESO. Again, they're not in the US yet, but pretty good example of doing, in this case, it's not a classic controlled trial. It's not an RCT in the sense because they're not randomized, they're propensity matched. But I think you get a pretty good sense that this is a workable way to go about it. There is a company in the United States now called Jiminy, which is doing exactly this as well for depression and anxiety, where they've moved from 50 minutes once a week to 25 minutes every 2 weeks by having daily interactions with an agent that helps with journaling and with support. If you saw the New York Times this morning, there's an article on the front page of the Times about this study from Dartmouth that was published about 2 weeks ago. It's gotten a lot of attention. This is moving one step closer to the Waymo idea. So in this case, that you don't have a human in the loop. This is providing an AI chatbot for mental health treatment. Again, the results are promising. I have a real problem with this study for a bunch of reasons. One of which is that, and maybe this is inevitable with an academic research project, but they ended up studying about 20% of the people who needed to actually get care. So they were very selective about who they took. They basically didn't take anybody who was sick. These were mild to moderate anxiety patients. They provided a chatbot that did CBT. You can see the results. There was, some improvement in the intervention group, but the control group was a waitlist control. So that's not awesome. That's not the way I would want to do an RCT. The one thing I think that was interesting that I would take from this study that I think was missed by the New York Times reporter this morning was they had surprisingly high rates of engagement with the chatbot. And that's what this funny heat map is on the right side of this slide. It just looks at the number of messages per day. And there were, not everybody, but a fairly large number of these patients really got into this. And they even talk about that in the article. They got incredibly attached to this chatbot. I don't know how much that was generational. I don't know how much that was related to symptoms, whether there was a gender difference, but we ought to take that seriously. I think that is the one piece of this which, for people like me, was not expected. That there are a lot of people who would prefer to have treatment with a bot than with a human. I don't see them actually in the company that I'm doing now, where we're trying to get people to use digital mental health. About 50% of people don't want to do that, but it may very well be that they selected people here for this trial who were willing to do it, willing to try it. And it sure looks like some of them got deeply, deeply involved and actually using this bot messaging with it many, many, many times a day. And of course, since it's available 24/7, that is a real advantage over seeing a therapist for 50 minutes once a week. I think where we have to go, if we're really thinking about the world with Waymo for mental health, is what you would do for more, not for the structural kind of manualized therapies like CBT and DBT, but for more insight-oriented therapy. And the question that a lot of people have been asking is, are we ready for that? And I just learned actually before in a conversation that using ChatGPT for therapy is one of the most heavy uses of an AI agent or AI assistant. But how much of it actually can support psychotherapy itself, in the sense that we often think about it, which is very different from just learning skills. It's actually learning to about yourself, and it's really focused on personal growth. There is a company called Slingshot, and I put up this long essay on their website, and I apologize for asking you to read this, but I do think it's worth taking a moment to look at it. Can you see that in the back? Okay. So the founders of Slingshot, who had been in other companies before, thought that they had a really great idea of using AI for psychodynamic psychotherapy. And they immediately figured out that the AI assistants as we have them today are exactly the opposite of what you need for psychodynamic psychotherapy. And first of all, you want an agent that can reflect on what you're not saying, not an agent that's just reflecting back what you are saying. But more than that, you want something that will challenge you. You want something that is not going to give you the answer that might be most popular. These, AI is sycophantic most of all. It is designed to make you like it and to make you like yourself. This is not what you want in a psychotherapist. And so Slingshot is saying we actually can't use any of the current models. We're going to have to develop our own model. And they've set about now collecting hundreds of thousands of psychotherapy data with the best therapists they could find to figure out, is there a way to do this? And actually, what's so interesting, when you talk to the founders, you don't see this very often in startups, but they say, we're not sure that this is even workable. We're actually pretty skeptical, but we want to try it. We think somebody should try it. And A16Z has agreed to give them $35 million to try to figure this out. So we'll see, I think, in the next year or so, how far they can get in developing this kind of what we'll call a foundational model, a new generative AI, a model that doesn't exist today, specifically for psychotherapy. All right, what about quality? I think one of the issues here around quality, so we've done clarity, we've done engagement, we've done capacity, quality. Some of it just is going to be about training. And here I was just looking at a company that's developing simulators for surgeons. And I thought, wow, that's just what would be great. And that's happening already here. There are quite a few simulators that have been built using AI to help people become better therapists, help them become better psychiatrists, to help them train up. What I think is one of the most interesting uses of this approach is actually, it's not a simulation per se, but it's been using AI generated content mostly to create communities, or we'll say community health workers in the developing world. So this company, which is called 4C, I think is kind of extraordinary. This is a company that has trained about 3,000 or 4,000 community health workers in Central Africa and 4 or 5 countries in Central Africa. The company consists of one person, happens to be my daughter, who is also raising 4 kids as a single mom. But because of access to something that can generate content like ChatGPT, and she's a very good therapist and she's done multiple companies before, she's been able to create an amazing array of content for people to learn how to deal with a whole range of psychological situations. So some of it is motivational interviewing, some of it's CBT, some of it's DBT, but she's created what is really a library that includes videos, podcasts. I mean, if you haven't used Notebook LM as a way of generating podcasts, you got to try this. It's an amazing, amazing technology, which helps somebody who wants to learn about, let's say, DBT, to figure that out very quickly by listening to a podcast of 2 people talking about what works, what doesn't, what's so hard. All of that is available today for anybody to develop and this to modify. And she has the advantage, because we're talking about African countries, that she can put it into local, kind of a local culture, and sometimes with the translations that you need for these other countries. So it's just, I put this example up thinking this would have been unthinkable 5 years ago. And yet for a single individual to be able to have that kind of impact in the developing world is pretty astonishing. And that's one of the ways in which I think we can improve quality as well as capacity in these places. All right, we're getting down to the end of this. Accountability, I just wanted to put this up to sort of clarify the importance of this. Paper from JAMA Psychiatry that was actually, it's about a decade ago, so it doesn't involve AI at all. It just does a very simple thing. This is actually I think a study that was done in Taiwan, and it was a study of a medication for depression. And one group, they did measurement-based care. That is, they had an outside group that actually measured outcomes, and the other group they didn't. What you see in the orange is the standard treatment. In the green is the group that got measurement-based care. And what is so stunning about this is just the power of simply measuring outcomes to improve outcomes. I mean, if we could put that into a pill, that would be a blockbuster drug by itself. Why we don't do this, why only 20% of providers are willing to measure outcomes, I don't know. But it does really tell you that you can get better responses if you bother to measure them. So we have a bunch of ways of doing this. I've already talked about some of them. You can collect voice and speech passively. It's just ambient. It's there anyway in the interview. And it's easy to use that to capture all of these different factors, including filling out rating forms passively if that's what you want, capturing wearable data and face and all of that. And I think the other way to do this is it doesn't even necessarily require a person to be in the room. You can do this. This is a piece you can do with an agent, where you can have a conversation with somebody and get all of this data that you need. And maybe it's not once a week. Maybe it's from 9 to 5. Maybe it's 8 o'clock at night, or on a Sunday afternoon, or wherever it's most convenient for the patient. So to summarize, I think we've got lots of opportunity here. I like to say that AI could be for mental health what DNA or genomics was for cancer, improving diagnosis, improving treatment, and here even fixing all of these aspects of practice, which I'll call the office assistant. It's not one thing, it's not one tool. There's lots and lots of tools that are becoming available. I know most of us have focused on the treatment side of this. I want to assure you that probably that middle box of the office assistant is going to have the biggest public health impact in the short term, and it's something that we're ready to do immediately. Doesn't require a lot of R&D. I think on the other two sides, on the diagnostic and treatment side, there's still a lot of work to do, and some of this to get the models right. But already, I think we're seeing the beginning of some very positive signs. So I tend to be pretty bullish about this. I think that the problems are serious, they're deep, but these tools are going to really help us make progress here. I'll finish with a few thoughts. One is that, every time I talk about this, I get questions about the downsides, particularly privacy, hallucinations, misinformation. My granddaughter came to me about 2 months ago. She'd been playing with an earlier version of ChatGPT. I think it was 3.5. And she showed me this conversation where she was asking ChatGPT, how many R's are in strawberry? And the answer it kept giving was 2. And she kept saying, no, they're actually, she's 12 or was then. There's actually 3 R's in strawberry. And it got very hostile very quickly, saying, no, there are 2 R's in strawberry. Look at this. And so she spelled it out, and they continue to make this mistake. And she finally, and the final, this went on for quite a while. The final comment from ChatGPT 3.5 was, I guess we'll have to agree to disagree. So it's not perfect. But when you look at what people are getting today, we have to be asking ourselves always, compared to what? I get it. There are problems with all of these tools. They aren't ideal often. And there's some things they do. April 15th, they do taxes really well. They're also great if you're going on a holiday and you want someone to develop an itinerary. Amazing how great these tools are for that. But not so good for loading your dishwasher, doing your laundry, and in some cases even spelling. I think in the mental health care world, we have such deficits. The wait times are so significant. I was just talking to somebody today who said that in the state of Washington, if you need to see a child psychiatrist, there's a 12-month delay. That's unacceptable. And so you don't have to be very good to be better than that. And I think we need to temper how we think about the risks with understanding that the benefits are real and immediate. And if we don't do this, shame on us. I like to say this because there's always somebody worried about losing their job. I don't think that we're going to replace clinicians, but I think the clinicians who use AI are going to replace those who don't, in the same way that Uber drivers replace taxi drivers. I just think that's where we're at. The efficiency is too great. And as people begin to understand that, this will become part of practice. I've already made this point that that the current tools for generative AI and co-pilots are not what you want for psychotherapy, at least for dynamic or insight-oriented psychotherapy. But they are really good for skill-based approaches. And I think that's a work in progress. We'll have to see where that goes. And finally, because there are many, many people in this room who are involved in studying this, I don't think we've figured out the right way to study many of these tools. It's really clear that the culture we have, which was developed for drugs and drug development, is not the right one here. The idea that you find a molecule, you put IP around it, you don't change it for 20 years, you get it through the FDA, and you make a lot of money 30 years later. That's just not appropriate here. I'm not sure that RCTs are the way to study any of these things. And we have to come up with what are probably better models for how we do that. So to finish, I said that we've got these 3 crises. We've got ways of addressing diagnosis, engagement, capacity, quality, and accountability. But these are just tools. And the fact is that what we really need is to deliver a whole bunch of services that we're not delivering. In every one of these crises, we know what to do. We actually know how to solve every one of them. It's not an R&D problem. It's a problem with implementation and delivery. So I think what we need to think about is, while these things are really great as tools, they're only going to be useful for ending this crisis as they get integrated into all of these kinds of services and approaches that we know are essential for actually addressing each one of these parts of the crisis. So I'll stop there, leave you with the Bill Gates quote that I always like to think about when we're in the middle of this and trying to figure it out. It's easy to overestimate the change that will occur in the short term and underestimate the change that will occur in the long term. I actually do think this is the most important innovation for mental health care that we've seen in the last 40 or 50 years, but getting it implemented is going to be a huge challenge. Thank you.